Good morning, everyone. It's a great pleasure for me, on behalf of the Norwegian School of Sports Sciences, to welcome you all to this trial lecture in partial fulfillment of the requirements of the award of Doctor of Philosophy, PhD, in Sports Science. My name is Truls Råstad, and on behalf of Rector of the Norwegian School of Sports Sciences, I will share the two sessions here today. And in particular, I would like to welcome the members of the Examination Committee, Professor Jorunn Sundgodt Borgen, Norwegian School of Sports Sciences, Chair, Professor Kristoffer Barfod, Department of Clinical Medicine, University of Copenhagen, first opponent, and Assistant Professor Jacobine Oosterhoff, University Medical Center Groningen, Department of Orthopedic Surgery, Groningen, the Netherlands, as the second opponent. Furthermore, I will welcome the candidate, Kyle Martin, who will give the following lecture: Treatment of Recurrent Patellar Instability and the Role of AI. Is it time to go all in, or is less more? I'm excited to hear the answer to that, so please.
Thank you. Good morning. Thank you, everyone, for coming today. I have no relevant financial disclosures. And so I've been asked to speak about two, by themselves, fairly complex topics in recurrent patellar instability and artificial intelligence. So I'm going to try to distill these down, and really the objectives for today are to go through the relevant anatomy, the risk factors, and the impact of recurrent patellar instability, as well as review the current evidence regarding the management, specifically surgical treatment and decision-making related to that. I'm also going to review whether AI can add or subtract from this current approach, and whether it can improve our understanding of patellofemoral instability and support treatment decision-making. So if we start at the beginning, we think about the patella, which is the kneecap, as a pulley system. And so the patella glides in the groove on the end of the thigh bone known as the trochlea. So ideally, this is an in-line pulley system, so in a straight line. The quadriceps muscle acts through the quadriceps tendon to pull on the patella, which then attaches to the tibia or the shin bone through the patellar tendon, causing the knee to straighten. So the patella normally tracks in that groove, again, the trochlea. But instability of the patella can come in two different varieties. So there's subluxation and dislocation. For the purposes of this talk today, we're going to focus on patella dislocations rather than subluxations. And we're also going to consider recurrent patellar instability to mean patients who have dislocated multiple times but have not undergone surgery, as opposed to patients who have dislocated after having surgery, which would be a failed surgical recurrent patellar instability, although most of the principles for the treatment remain the same. To give you an idea about the possible clinical scenarios we may be dealing with, this could be anything from a 26-year-old male rugby player with a contact injury to the patella, or a 12-year-old female gymnast with a non-contact twisting injury. They may present with a knee that feels vaguely unstable. Pain and swelling is pretty common, and it may relocate spontaneously or go back in by itself, and sometimes it requires a trip to the hospital or someone else to put it back into position. Either way, sometimes patients will say, I felt my knee dislocate, or I felt it pop out and went back in. And the management, although the problem is the same, the management for each of these patients might be very different. So why is this important? Why does it matter? Patellofemoral instability has been shown to represent about 3% of all sports-related knee injuries, so it's pretty common. And more importantly, that high rate of recurrence in the middle there, it's been found that in some populations, and depending on risk factors, that after the first patellar dislocation, the recurrence rate can be as high as 86%. Similarly, it's been shown to result in significant functional limitations and pain, which has been associated with a similar level as an ACL rupture. So besides the obvious consequences such as pain, swelling, functional limitations, and persistent instability, these injuries can also result in serious injuries to the cartilage, which may lead to osteoarthritis of the patellofemoral joint in the long term. I mentioned earlier that ideally the patella will stay relatively midline throughout the knee range of motion, but it actually does shift somewhat through normal motion in someone who doesn't have patellar instability. Relative to someone with normal tracking, however, the patella sits more laterally or out to the side throughout the motion in those patients who do have instability. In general, the patella is most vulnerable to instability between 0 and 30 degrees of flexion, meaning the leg all the way straight to that first 30 degrees of bending. I group these as kind of three main areas or factors that can contribute to patellar instability, and they work together to keep the kneecap stable. These would be the bony anatomy, the soft tissue restraints, and then also the force vector. Again, it should be in line. And problems with any of these three can lead to a higher likelihood of experiencing a dislocation. There are two main categories of bony restraint problems, and the first one is patella alta, or patellar height. And so patella alta refers to a patella that is higher than normal, and what that can lead to is when you go through that first 30 degrees of flexion, that kneecap normally engages in that groove, but if it's too high, it doesn't quite engage yet, so it's more prone to dislocation. Trochlear dysplasia is the other main bony restraint problem, and this refers to changes or abnormalities in the shape of the end of the thigh bone, so that groove, the trochlea. And pictured here are the kind of 4 different varieties of trochlear dysplasia, from a narrow or shallow groove rather to more of a flat one. This is one of the more complicated or complex areas of bony anatomy around the knee, and so I credit Dr. Mark Strauss for this excellent picture here, which kind of simplifies it a little bit. So we can all understand that the picture on the left, that patella is sitting in the groove. So it's in a valley, and it's pretty hard to get it over that hill to get it on the corner and off the groove. In the middle one, it's more like a plateau. It's flat, and it's obviously much easier. It takes less force to roll that patella off and dislocate it. The worst case scenario is the far right, where it's more like a cliff and it's perched. It does not take much force at all to dislocate that kneecap. Soft tissue restraint problems. We think about the soft tissue stabilizers as being dynamic or static. The dynamic ones would be the quadriceps muscle, and the static are more the capsulo-ligamentous structures. The most important of these would be the medial patellofemoral ligament and the medial patellofemoral ligament complex. I mentioned earlier that the patella normally acts as an inline pulley system. Several factors can cause this pulley system to encourage more lateral tracking that can lead to instability. The first is leg alignment. And so if you think about a straight line from the center of the hips down to the center of the ankle, ideally that line will pass through the center of the knee. You can deviate out or in, and the variety we see here, if we draw that straight line, being slightly more knock-kneed leads to patella that tracks more laterally and is more prone to dislocation. Rotational deformities of the bone can also contribute in that the femur, the thigh bone, can rotate in as it goes from the hip down to the knee, known as increased femoral anteversion. And the tibia can also rotate out from the knee down towards the ankle, which is increased tibial external rotation. Both of these can lead to a force vector that pulls the patella more laterally. An important concept here is the tibial tubercle to trochlear groove distance. And so if we look at the end of that thigh bone here, that groove, if we look at the center of it, that's the center of the groove that the patella is tracking in. This dotted line represents the insertion of that patellar tendon on the top of the shin bone. And so if this point where it attaches is more lateral, leading to an increased distance between the tibiotubercle and trochlear groove, it again suggests that the patella is tracking more laterally. This can be because the tubercle is more lateral or because the center of the groove is more medial, which we see in trochlear dysplasia. Tightness of the lateral structures over here can also lead to more pull laterally and higher risk of instability. Other non-anatomic risk factors have also been described, including generalized ligamentous laxity, for example, being double jointed, pictured here, very flexible, can lead to less soft tissue restraint on that patella. Young age, female sex, and hereditary factors, with certain populations being found to have significantly higher rates of trochlear dysplasia, for example, and higher rates of patellar dislocation. Faroese from the Faroe Island, for example, have been identified as higher likelihood of experiencing these problems. Of all of the risk factors identified so far, the most important are the bony stabilizers. So trochlear dysplasia, patella alta, and that increased TTTG distance, or that lateralized tubercle. When it comes to the soft tissue stabilizers, the MPFL is the most important. Labeled here as the MPFC, the medial patellofemoral ligament complex. This acts like a check rein or a seat belt, keeping the patella stable throughout that range of motion and preventing the patella from tracking laterally. The patella, when it dislocates, the vast majority of the time does go out laterally. Medial instability is more often caused by either surgeon error or specific issues that are not going to be discussed today. The treatment of patellofemoral instability depends on when you see the patient. And if you see this patient acutely with a kneecap that has not yet been reduced, it is still sitting dislocated, the first thing you need to do is put it back. And you accomplish this essentially by straightening the leg, applying some gentle pressure to the side of the kneecap, and then pop, in it goes. This is why it can happen spontaneously, and many patients will maybe have it pop out and then go back in, is if the quadriceps contracts and the leg straightens, it can drift back into place. When you see these patients acutely, give them some ice, some compression, maybe a knee brace, elevation, and get some x-rays. Either if you see them down the road after it's already happened in the clinic, the next thing you do is order an MRI, begin a course of physiotherapy, and have a discussion regarding possible surgical management. And the discussion about surgical management often revolves around whether this is a first-time patella dislocation or recurrent instability. In the first-time patella dislocation, indications for surgery, the main one would be an osteochondral fracture. So that means if the kneecap, when it went out, knocked off a piece of cartilage or a piece of cartilage and bone, and the piece is loose inside the knee joint, for example, that's a patient who should have surgery. Otherwise, in the absence of that osteochondral fracture, the management of the first-time patella dislocator is somewhat controversial. Many algorithms and scoring systems have been developed. This is an example here from Mario Havesi, the RIP score. And you can see on the side here that there's a scoring system based on risk factors. And all of this goes into your discussion with the patient to decide on whether to proceed with management non-surgically or surgically. Most will advocate for rehabilitation initially. However, you'll see, and admittedly it's somewhat confusing how they reported it, but the 10-year instability-free survival is only 20% in patients who have 4 to 5 out of 5 points from up here. Put another way, patients with a score of 4 to 5 have an 80% chance of a redislocation over the next 10 years. And that's a discussion you can have with patients because every time that kneecap goes out, you risk doing damage to the cartilage, and that can prevent or present as osteoarthritis down the road. So sometimes there is a role for surgical management early on. Either way, it's shared decision-making with the patient. Thankfully, today we're not going to talk further about first-time patella dislocation. We're talking about recurrent patellar instability. And in this case, it is much more straightforward whether to do surgery or not. The vast majority of surgeons would advocate for surgical stabilization of the kneecap if it's been dislocating more than once. Although the decision of whether to do surgery or not in the setting of recurrent patellar instability is fairly straightforward, the choice of what surgery to perform is less so. Many different procedures have been developed and described over the years with the overall goal of improving the force vectors and patella stability through restoration of the soft tissue restraints and correction of the bony abnormalities. Soft tissue procedures over here are essentially to tighten the medial structures and lengthen potentially the lateral ones. The bony ones are defined to treat the underlying bony abnormalities. The tibial tubercle osteotomy involves cutting the insertion of that patellar tendon on the shin bone and moving it either inwards to prevent the lateral dislocation or downwards to correct the patellar height. The femoral and tibial osteotomies can be performed to correct the rotational or knock-knee alignment for these patients. And trochleoplasty is a powerful correction to reshape the groove on the end of the femur to create more of that valley and stabilize the patella. By far, the surgery performed most is the MPFL reconstruction. So this is the workhorse procedure designed at recreating that ligament attachment from the inner aspect of the patella over to the attachment on the femur. Again, that's that seatbelt or check rein. Many surgeons will advocate for an isolated MPFL reconstruction as the first treatment of choice for patellar instability. This is because it has been shown to decrease patella alta, or bring the patella height down, improve patient-reported outcome measures, comes with a high return to sport rate, and a low recurrence rate. But I just finished saying that the bony factors are the most important contributors to patellar instability, and the MPFL reconstruction alone does not address those. And as we've also seen, there is a higher risk of failure with an isolated MPFL reconstruction when you have that patella alta, the increased rotation of the femur, lateralized tibiotubercle, or trochlear dysplasia. There is no consensus, but because of this information, there's an increasing push to personalize the management for these patients. A few algorithms have been developed to help guide personalized surgical management, and this is one example here from Dr. Dejour in France, the menu à la carte. And in this, all patients who meet the operative treatment criteria will go on to have an MPFL reconstruction. So that's the baseline, everyone gets that. And then based on the presence of other factors such as trochlear dysplasia, patella alta, increased TTTG, or medial patellar tilt, there are other procedures that you would add. The Copenhagen patellofemoral instability algorithm expanded upon the menu à la carte and includes long bone osteotomy or realignment as well. So similar, everyone gets the MPFL reconstruction, and you essentially treat what the problems are for each patient. Dr. Dejour's group has said that the menu à la carte have helped us to successfully and better treat patellar dislocations that once seemed impossible. However, we could clearly state that not all the answers have been found, but we are moving closer to the goal. So what is the goal, and how do we continue to make progress towards it? The goal is essentially to optimize the health of our patients. We want to restore patellar stability and patient function. And we also want to minimize both the short and long-term risks and consequences. This is not unique to patellofemoral surgery, but anything we see every day, this is our goal. Laurie Heemstra, a Canadian surgeon in Banff, patellofemoral guru herself, has said, how much better would we be able to treat patients if there was a reliable way to assess the risk of injury, predict failure, or guide the need for extra procedures? Tools that will aid surgeons in these questions are the holy grail of patellofemoral surgery. What Laurie is touching on there is part of the art of medicine, navigating the gray areas of clinical care. For every patient we see, we collect information from various sources to help us decide what to do next. We ask questions, we take a history, we perform a physical exam. Sometimes we look at imaging like x-rays or MRIs or CT scans. Occasionally blood work can help. And we take that information and we put it into the context of our own experience and understanding of the literature and best available evidence. There's an increasing realization that AI may be able to help us navigate these gray areas, because essentially what the surgeon is doing is creating an algorithm in our head. AI can also do that. But what is AI and how can it help? An understanding of the common definitions and structure is important in any conversation about AI, and I think there's a few important concepts that we should all understand and to highlight today. The first is artificial intelligence, the main branch, which represents and refers to automated analyses and human mimicry by computer algorithms. Machine learning is actually a subset within AI, which trains algorithms to find patterns in data and make predictions on future or new data. Deep learning is a further branch focused on neural networks to accomplish much of the same tasks that are slightly more complex without human direction. And within deep learning, we also find the field of generative AI. Overall, I'd say our general familiarity with AI is growing, and by now we've all come across it in one way or another. We see AI in our medical journals, our Black Friday deals, targeted ads, our voice recognition software on our phones and in our homes, and in the news. But what makes this technology so appealing when it comes to problems like patellofemoral instability? When I think about the role of AI in patellofemoral instability, I classify it into 4 main categories. First one we'll touch on is computer vision. And this is a generic term that refers to the automated interpretation of images and video. The example on the right here, ChecksNet, is the first real great application of computer vision on medical imaging, which was done through Stanford. And it was trained to detect pneumonia on plain radiographs. These algorithms can work on either 2 or 3-dimensional images, 2-dimensional being X-rays, 3-dimensional being more of those CTs, MRIs. And the tasks can be divided into classification, object detection, and segmentation. I'll present 2 orthopedic examples here to illustrate the difference between these tasks. So classification function is used to identify the appropriate class the image belongs to. For example, in the first one here, meniscus tear, present, yes or no. Hip fracture, present, yes or no. Classify either dichotomy, yes or no, or into a different category that's been predefined. Object detection identifies the presence or absence of the object and marks the location using a bounding box. Normal meniscus here, tear here. Hip fracture located in that box. Segmentation goes further and identifies the area, including the exact pixels. Here is the meniscus tear, here is the hip fracture line. In patellofemoral instability, we often rely on 3-dimensional imaging like CT scans or MRI to measure several important metrics associated with patellar instability that can be used to guide management. However, the management of these metrics is time-consuming and often comes with low levels of inter-rater and intra-rater agreement. So different people can make the same measurement on the same patient and get very different results. An example is a simple measurement like the patellar tilt. A line along the bottom here connecting the bottom of the femur or thigh bone and the long axis of the patella. These images are in the same patient using different slices. And if you don't have agreement regarding which image or slice to use, you can get different values. The one on the left is measured at 18 degrees, whereas the one on the right is 22 degrees. It may be a small difference, but that might be the difference between surgical management or not. And remember, this is the same patient. On the bottom here is the same patient with 3-dimensional imaging, which allows you to better appreciate and define the whole 3-dimensional anatomy. Because although we think of CT scans as 3-dimensional imaging, it's still broken down into 2-dimensional cuts to represent that 3-dimensional object. Moving to more of a 3-dimensional analysis, we'll be able to streamline and standardize the measurements and can also be done more rapidly rather than someone doing it themselves. The assessment of trochlear dysplasia is an area of patellofemoral instability that I think is ripe for AI innovation. So again, it's a complex 3-dimensional problem that is challenging to classify, and this one has consistently low levels of agreement between experts. But despite that, it represents one of the most important risk factors for recurrent patellar instability, and accurate identification of trochlear dysplasia can guide surgical management decisions. One study has recently been able to develop a model that can identify trochlear dysplasia, and this is a classification task to say whether a patient has dysplasia, yes or no. Interestingly, it was able to identify trochlear dysplasia better than junior and intermediate surgeons and similar to level of more senior surgeons. Again, it wasn't a classification in terms of the grade or type of dysplasia, but just having it yes or no. It also performed it in less than half a second, compared to about 90 seconds for the intermediate doctors and 1:45 for the junior doctors. Added up over multiple patients, that's a significant amount of time savings. John Fulkerson's group at Yale have also leveraged AI to help understand the trochlear anatomy, which is shown here. Patients in the top row, the same patient here, has trochlear dysplasia. This patient has a normal trochlea. This is a 3D curvature analysis to show where the curve on the edges of the trochlea are. In the normal patient, it's more of a straight line with a trough in the middle to allow a much longer groove to have that patella engage and track centrally. In those patients with more of a curve, the dysplastic trochlea, The patella is encouraged to start out laterally and then comes into the groove throughout motion. It's a much shorter groove. Taken in cross-section, we can also appreciate that, again, this is very flat, whereas this has the normal groove. It's also able to pinpoint and identify these areas on cross-sectional anatomy that way. Although the clinical utility of this has not yet been established, I do think that this will help guide clinical care in one form or another in the future. Models have also been developed to rapidly and consistently measure leg alignment. So this is showing an example of me dragging and dropping an image, and then voila, we get the measurements associated with, in this case, knock-kneed, so not necessarily an increased risk of patellar instability, but another clinical problem. But you see all the measurements that come up consistently and rapidly, much quicker than if I were to measure them myself, and can be used to guide surgical decisions and planning the actual surgery. More specific to patellofemoral instability is the measure of patellar height. Again, drag and drop an image, and you can see an automated measurement down here. It's faster than I am scrolling. Here we have the points marked on the patella, and here we have the ratio. So the Caton-Deschamps ratio is a measurement that we use to define whether someone has a high patella, a patella alta. Typical cutoff for considering it to be high would be 1.2. This patient has 1.13, so there's no patella alta. But you can see how doing a rapid, standardized assessment like this means that everyone is using the same measuring stick when we're talking about our patients, and it's much quicker for us to do. This could be incorporated into our radiologists' automatic reads or into other avenues to collect the data in a standardized fashion. Moving on from computer vision, we can turn our attention to registry creation. A brief history of registries involves looking back to the first registry in the world, which actually started in 1856 here in Norway with the National Leprosy Registry. The orthopedic registries came a little bit later, in 1975 in Sweden with the first arthroplasty or joint replacement registry, followed by the Norwegian Joint Replacement Registry in the 80s, and the Norwegian Knee Ligament Register started in 2004. And this was the first knee ligament registry in the world and focused primarily on ACL reconstructions, not patellofemoral instability. The goals of a registry are in three main categories, and that's quality improvement and benchmarking, resource allocation, planning, and improved patient outcomes. As of right now, there are currently no national patellofemoral instability registries in the world, although I'm happy to hear that the Norwegian registry will begin collecting information on these MPFL reconstructions and related treatments starting in January, I believe. Regarding the quality improvement and benchmarking, the goal here is really to identify outliers. These outliers can be regarding surgical trends. Are people keeping up with the times or using antiquated techniques? Costs. Is it costing more in certain regions or surgeons than others? And also for outcome tracking. This can be done at the region, institution, or surgeon level, although not all registries are created equal, and some registries, like the Norwegian one, for example, do not collect information at the surgeon level. Some registries, like the one in Canada and Manitoba, you actually get feedback from a standpoint of your individual practice because it is at the surgeon level. And if you are deviating from the mean, they can flag it and discuss remediation. Resource allocation planning is the second main area, and this is to allow us to follow epidemiological changes over time. This ability to forecast can help plan budgets and resource allocation, but also maybe potentially recognize areas for optimization. If there are certain procedures that are performed at very low volumes in some locations, it might be worth centralizing to other high volume centers, although that can also relate to whether the outcomes are any different or not. The last, and I'd say most important area of registries is really to improve patient outcomes. And so this is done by being able to identify factors that are associated with outcome, and specifically early identification of inferior techniques or implants. And this is set up initially with the arthroplasty register to say that based on the number of procedures performed in a year, we're able to say, but if there are 14 failures with a given implant or technique, certain cements, for example, that constitutes a flag that should be raised and investigate that implant. And that allows much earlier detection than if you were to not have a registry and just follow these patients in silos around the country. This allows earlier identification. It also collects real-world big data for research purposes, and it's also more generalizable than a randomized controlled trial. So randomized controlled trials may be at the peak of the pyramid when it comes to evidence, but they're also oftentimes more of a tightly defined group. You might have inclusion criteria of patients between the ages of 25 and 50, which doesn't help you when you're seeing patients who are outside of that range. It also might include patients with certain comorbidities or things that are outside the realm of what you're seeing. The registries, on the other hand, collect data on everyone in the country who's undergoing this procedure or has this health issue. And so it allows for more generalized interpretation of any sort of results from these studies. It also allows faster recognition of impact of changes to clinical practice. If a new technique is instituted, you can see much quicker because you have rapid collection of large amounts of data. You'll be able to see how they're doing quicker than if you didn't have that registry. Patient-specific prognostication is the last part that is clearly near and dear to my heart, as that represents my thesis. Over the years, again, 50 years of the orthopedic registries in Scandinavia here, many different papers have been published that have highlighted exactly what I was talking about. Implants or techniques associated with higher rates of failure, reported on outcome, epidemiology, and patient-specific prognostication. The data sources for the registries come from a few different locations. Patients provide information, they fill out surveys and give information about themselves. Data can also be pulled from the health record, but then also surgeons completing forms. And so if we were to use an AI-supported registry for patellofemoral instability, I see a potential to be able to automate much of that data collection. This can be done through patient-facing apps, can maybe encourage higher compliance rates, but then also using computer vision, like I showed earlier, to standardize some radiological measurements that currently are not being collected, and also using large language models to pull data from the clinical record. So large language models, the most common or most recognized would be ChatGPT, are within the field of natural language processing, which is a broad field that focuses on enabling computers to understand, interpret, and generate human language. So this is useful if you've played around with ChatGPT for reading, analysis, and interpretation, writing, or if you're just looking for someone to talk to. An example of how this can be used clinically, taken from my work with the ACLs, is this is me starting a conversation with ChatGPT, and I'm essentially asking ChatGPT to pull information from an operative report that I have generated that is information that is normally asked for by the registry. So the current workflow is the surgeon leaves the operating room, they sit down and they dictate their operative report, and then they step over and fill out a registry form. Most of that information is in two spots. You're duplicating work. So here I am pasting my operative report. Again, this is ACL, not patellofemoral. And this is a fake patient, so it's not patient information I'm putting in here, but it follows my normal template that I use for my operative reports. So you can see that there. Scroll all the way down. This is a right knee ACL reconstruction with a meniscus tear that was repaired. And then you hit enter, and it's almost instantaneous where it produces the information that I'm looking for. The information that would be pulled by the registry is there. So how did it do? Side, it said right, and that was correct. Was there an ACL reconstruction performed, yes or no? Yes, correct. Graft choice, it correctly identified that we used a hamstring tendon autograft. Was there a meniscus tear? Yes. If so, which one? Lateral meniscus, not the medial. If it was medial, what was the treatment? That could be seen as a trick question because there was no medial meniscus tear, but it correctly identified that there wasn't one, so it said not applicable. If the lateral, what was the treatment? Correctly identified that there was a repair. Femoral socket tunnel diameter, 8 millimeters, tibial, 8 millimeters. That alone would save the surgeon a bit of time because all of that information they'd have to duplicate and fill out manually right now. It performed 100% on this little small sample size, this one example. This is something that I'm working on back home, again, starting with ACLs, but you'll see that we're also including, as we do this, MPFL. So we're starting to input patients with ACL tears and meniscus tears, but eventually we're going to expand to MPFL. And we're setting this up using English language and then translating to other languages eventually too, to be able to automatically pull the data from the operative reports with the goal of decreasing the work that the surgeons will have to do. We'll get into it later, but we know that right now we currently need to collect more information, but we can't ask the surgeons to do that, because by asking the surgeons to write down more things, compliance rates go down, data quality suffers. So taking the load off of the surgeons, removing those easy, low-hanging fruit variables, and allowing them to focus on the variables that you can't pull automatically is the goal. My vision for an AI-enhanced or supported patellofemoral instability registry is here, pulling from the electronic health record, again, the operative reports, the clinical notes. You can also add physiotherapy notes, follow-up notes, to pull that data automatically. The patient-facing apps, including other registries, which will have information regarding comorbidities, other diseases, other determinants of health, social, economic status, etc. The computer vision, right now we're not actually including in the registries any sort of measurements from radiographs or including the images themselves. If you can collaborate with the radiology department and bring those in automatically, you can standardize a lot of the measurements like I showed earlier. You can't get away from manual entry, but if you can cut down on the number of variables that you're asking surgeons to complete, you would anticipate the compliance rate goes up, and you can focus the manual entry on those factors you can't get automatically. Wearables is another area that I think will probably play a role in the future. We don't really know how to interpret or use that data yet, but so many people are wearing watches or other fitness devices that are tracking, or we can create some medical devices that will help us follow patients through their rehabilitation journey. The other advantage to this is that it allows us to collect information prospectively. So if we started this now, we can use it going forward. But because it pulls information from existing documents, we could also pull this retrospectively. So that means that institutions or nations that don't currently have a register could start this and insert all of their documents they have from before and have somewhat of a baseline. They'd be able to collect data retrospectively. There would be higher rates of missing data because it wasn't done prospectively, but it's still usable data. And so if we move on to a topic, again, near and dear to my heart, we'll talk about predictive modeling. To put it simply, patellofemoral instability is complex. These are some of the risk factors that can contribute to patellar instability. Over 30 have been described. And so being able to navigate the patient sitting in front of you and say that these are all the different factors that contribute and interact with each other, it's hard to really dial down and say, you know, your risk is this, your risk is that, and really quantify it and guide that patient-specific treatment. So the accurate outcome prediction is crucial because it allows us to guide those discussions and make decisions on what to do. In 2025, the existing algorithms I showed earlier do provide guidance and good patient outcomes, but the true patient-specific decision-making is elusive. I do think that in the future, AI might be able to help. It can navigate those complex interactions and various risk factors and can potentially more accurately predict those patient outcomes. Just to toss out an idea, and I have to give credit to Ivan, who's up there. We were talking about this last week. There's also the potential for screening and maybe an earlier intervention for these patients. And so given that genetic predisposition, would an early identification of risk through maybe blood tests or other means enable an earlier treatment intervention, such as bracing or splinting, maybe as an infant, to correct that bony abnormality? This could be similar to the treatment of hip dysplasia. So for those who don't know, you can identify as a child a patient who has a hip click, or even in utero with ultrasound who has hip dysplasia. You put them in a brace when they're a newborn, and you can allow that bone to shape more normally. Similarly, we can identify patellofemoral instability risk factors like trochlear dysplasia in utero. And so, I don't know, maybe there's a future where we can identify these patients early through screening, provide a brace or splint or some way encourage that trochlea to shape more normally. Again, this is a long way off, but one could see how this could be a realistic possibility for the future. The final area I wanted to discuss is surgical planning. And when I think about surgical planning, I would say that this is in the very early stages, but probably not that far off. I showed a lot of the computer vision or image analysis modalities, And that can really allow us to nail down the complex three-dimensional anatomy and help that surgical planning from a three-dimensional standpoint. The goal is to get from here to here in a reliable and standardized fashion. Has not been developed yet for this area, but is in other areas of orthopedics like joint replacement or spine surgery. You can have navigated surgery intraoperatively, robotic-assisted surgery, and virtual reality or augmented reality supported with different techniques coming down the pipe. Now, all of this sounds great, but it's not to say there aren't challenges. Of course, there are the upfront development costs, which can come in the form of personnel, hardware, software, time. Then there's also the long-term maintenance costs associated with this. I think paramount is the protection of patient data and privacy. We have to make sure we do this the right way. Patients would expect no less, and nor should they. So it is paramount that we make sure data is protected every step of the way. Collaboration. This is not something that can be done just as an orthopedic surgery group. You need to involve experts in various different fields from a multidisciplinary approach to make this work, including hospital administrators. And we also have to make sure that we have ongoing monitoring of model performance. What works today here might not work tomorrow or there. And we have to make sure that whatever we implement is monitored to make sure that it continues to work. What we don't really know is what constitutes an acceptable level of decrease in model performance before we have to retrain a model or update things. Other challenges relate to the data itself. Not only do we need a lot of it, but it needs to be quality data to be useful. The saying goes, garbage in equals garbage out, and we can't rely on poorly collected data to develop our models. So examples of data problems relate to the inconsistent gold standard we use to inform our decisions currently. Poor inter-rater reliability on most of the measurements and classifications really limit the ability to agree on not just the optimal treatment, but also on the presence or absence of those risk factors to begin with. If the world experts can't agree, how can a model reliably use that data to come up with something that is useful? The other thing is, what outcomes are we going to predict? There are so many different outcomes that could be of interest to a patient. Failure of a graft, recurrent instability, patient-reported outcome, ongoing pain, arthritis, return to sport, as some examples. Failure and redislocation are relatively easy to report, but others may be less straightforward. The other thing is those patient-reported outcome measures that we like to use are really only valid in the population in which they've been tested. Commonly, white men of good socioeconomic status, so there's also some gender and class bias in there as well. Racial bias can also exist. There are some emerging guidelines, COSMIN guidelines, for example, to kind of standardize the PROMs that we're using, patient-reported outcome measures that we use, but still for patellofemoral instability, there's still some controversy. At the end of the day, not now, but soon, we're going to see more of these innovations impacting clinical care. Hopefully it's done in the right way, and hopefully we can be a part of that. Overall, the summary today is patellofemoral anatomy is complex, recurrent patellar instability is complex, and the optimal management does remain controversial, although there is more of a push for that patient-specific treatment approach. AI can potentially support us in that goal through imaging, registries, outcome prediction, and surgical planning and execution. It does require rigor, care, intention, and collaboration to do this the right way, though. References, and that is it.
So thank you for the lecture, Kyle. And I guess we still have to wait a little bit before we go all in.
Correct.
Yeah. We have time for 2 short questions. Yes, perhaps just to get, yeah, that's, and then you can sit or stand, that's up to you.
Thank you very much, Carl, for a didactic, brilliant lecture. I like the way you started with the clinical part and then went into the future and the possibilities of AI. I will bring it back to the clinical part, and then I'll leave the AI maybe for Jacobian, and ask a rather simple question, because we have this dispute between the States and Europe on how to treat these patients. So from what you have read and what you know, how would you advise your fellow surgeons and patients who have maybe trochlear dysplasia, who have recurrent patellar instability? Should they have the full package? Should we go in, derotate their bones, do trochleoplasties on them? Or should we try to do it maybe the more simple way with an MPFL reconstruction and a tibial tuberosity transfer?
Great question. Thank you. And I'm biased. So although I'm Canadian and working in the States right now, I trained in Europe as well. So I do the derotational osteotomies. I do the trochleoplasties. So I follow the algorithmic approach. So again, that's my personal bias. But you're right that in North America, particularly in the United States, there is more of a MPFL reconstruction first mentality. I think it's changing. I think there's greater appreciation for the importance of the three-dimensional anatomy. But it's not quite where it is in Europe and Canada and the States right now. I believe if you correct the underlying abnormalities, you give the patient the best chance of having a stable patella and meeting our goals. But that's not without risk. More surgery, potentially a very big surgery with multiple procedures, can be more morbid. And so that's a discussion with the patient with shared decision-making that I think would benefit greatly from more of these patient-specific prognostication, to be able to tell a patient, you know, you have this % risk if we just do an MPFL versus this % risk otherwise. Again, we're not there yet. So in my current practice, it's more algorithmic, using the cutoffs that have been described by your group, the Copenhagen patellofemoral instability algorithm, or de Jour's. I do like the Copenhagen one, again, because of the derotational and the coronal plane osteotomy, because I do both of those procedures. So that's my clinical care approach.
Thank you.
Well, first of all, thank you for your amazing lecture. Also, as introduced by Christopher, I will focus more on the AI aspect, but the lecture introduced the anatomical aspects perfectly, so that even I was able to understand it. And so my question is more going to be on the intersect of the old way of working and the new way of working. So often people tell me like, hey, you tend to buy new shoes before you use your old shoes. And looking at the algorithms that we had before, the menu à la carte algorithm and the Copenhagen instability algorithm, shall we just throw them out and trust AI to develop the better algorithms, or can we maybe use the more traditional algorithms and upgrade them, or what's your view on that?
Great question as well. I think that more of a stepwise approach where you continue the status quo of using the developed algorithms, whether you choose a menu à la carte or the Copenhagen patellofemoral instability algorithm, continue with that clinical care, because I do think that represents standard of care right now, best practice. If we can integrate AI initially to standardize some of the measurements, some of the tools we use to collect that data as well, that will then allow us to follow those patients long-term prospectively. And once you get that larger data set, that's when you can dive in and say, these patients followed the algorithm. We can maybe fine-tune those cutoffs. What measurement constitutes the cutoff point where you should consider this procedure, this osteotomy, this trochleoplasty? So I think that it's more of a stepwise rather than abandoning one in favor of the other. AI is not going to replace decision-making, but it's a support tool. It adds to our toolbox, just like the history, the physical exam, but hopefully standardizes those measurements to help guide us with more consistent outcome predictions, would be my vision.
Thank you.
Okay, so by that I thank the candidate again for his lecture, and I invite everybody to return to the auditorium at 1 p.m. And provided that the examination committee finds the trial lecture acceptable, the candidate will then define his thesis, predicting anterior cruciate ligament reconstruction outcome, machine learning, analysis of national knee ligament registries. So by that, I thank you all and welcome you all back at 1 o'clock. Thank you.